In the CSA, there are a number of CSA scenarios which have been created to test how you manage a consultation in which you just don't know or have the answers the patient is seeking. It may be around a condition that you could never have heard of, a medication you could never have heard of, or a procedure of which you have no knowledge. More likely, however, you are going to actually be faced with a consultation that you ought to know something about. It may be Hockham, it may be Huntington's chorea, or hereditary spherocytosis. Suddenly, all the knowledge that you had dribbles out of your ears, you start to panic, and then things start to really go wrong. Fortunately, Flanagan and Roylance have written a consultation model for dealing with this situation, which is not only relevant for the CSA, but in everyday life. In their experience, what happens if you don't prepare for this situation is that as that understandable anxiety overwhelms you, you stop hearing what the patient is saying, you start missing the verbal, the non-verbal cues. Your questioning starts to become a little chaotic, unstructured. It's actually very easy to miss the nub of the consultation. What were they testing in this scenario? Why is the patient really here in front of you? And as a result of which, the second half of the consultation spirals down into disaster. Fortunately, you can avoid this, but it does take preparation and rehearsal. If you have a look on the Pennine website, you will see that there are CSA scenarios around a patient seeking advice about Down Under syndrome or the medication for MS Wondersin. And certainly I'd advise you to try Flanagan's and Roylance's approach using these models, as this will give you confidence should you find yourself in that situation. With regards to the model, it actually takes a great deal of Flanagan's consultation model, but with some slight changes and particularly a real change in emphasis. So, first of all, just like all consultations, it starts with the welcome. Hi, I'm Dr. Smith. Do take a seat. How can I help you today? Then they come out with the opening statement. And it's at this point that the world starts to fall out. Doctor, it's my brother. He's in Sydney and has just had a baby and been born with Down Under syndrome. And, he was on the phone and it was a terrible connection. And he said it was something that runs in families. And I really need to know a little bit more. So, Flanagan Roylance say, don't panic. This is something that you can manage. The most important thing, just as in normal consultations, is actually make sure you're listening to the cues that are seeded in that opening statement. Already you know it may be a genetic condition. It's called Down Under syndrome. And there are some pressing issues as to why he in front of you wants to know more. So they say what you've got to do is reflect all of these cues back in turn, and in such a way that when the patient responds, they talk about that issue which is most dominant to them. You mentioned it running in families. You mentioned Down Under syndrome. What did your brother say about this? You mentioned that it really needed sorting out for you. What was going through your mind when you said that? And if you actively listen to this reflection of the cues in the opening statement, within the answers themselves is not only information, but further cues that you can then reflect back to expand your knowledge of the patient's understanding of the situation. Having done this, of course, the next step is to actually have a look at their thoughts, their worries, their hopes, formalised of course, and directly explore these, either with direct questioning or using some of the other conversational approaches, such as square searching, the Google factor, statement as a question. Also, you've actually got to spend some time understanding the psychological impact. What does it, what's the impact for him, his partner, how's the brother coping? You've got to then explore that social impact, and again, in the context of home, his relationship, work, hobbies, as taking this approach, delivered in a conversational way, will often give you a whole wealth of information. And quite a lot of this information may then help in terms of your focused questioning. So for example, if we took that genetics down under syndrome, what you then may be able to do is actually think, okay, I need to ask about family history. Has he had any children that have had any problems after birth? Or has he had any children with prior partners that have been affected? Are they thinking of having children in the imminent future? Are they using contraception? So the information that you gather through this detailed exploration of their thoughts, their worries, their hopes, psychosocial impact, will enable you to start to ask some logical questions. It may simply be just around the symptoms or the system, which part of the body has been affected. It may also trigger thoughts around some perhaps appropriate red flags that you need to ask. You may need to examine the patient, and you have to actually think, bearing in mind I know so little, is there value in examining the patient? Certainly there may be value in examination with regards providing credible reassurance to a patient. With regards to the data that you have gathered, there may be a system that you want to examine to establish if there are any relevant abnormalities. Having done this, what Flanagan and Roylance say is you've actually got to invest in a summary which is actually slightly longer than the normal Flanagan micro summary. Because what you've actually got to do is check in with the patient that you've got the nub of the consultation correct and you've correctly identified the questions or the issues that need answering or addressing. So this should really be taking place no later than minute 6. And by detailing what you believe to be the key issues facing the patient and the questions that need answering, you then have to ask the actual patient, is there anything I've missed? Give time for silence. Look them in the eye. Okay? Because if you've got the nub of the consultation wrong, the patient or the simulator will normally put you on the right track. If you've actually got it right and the questions or the issues that need addressing are exactly right, you know that you're in a confident position to actually score some additional marks. The next step is actually being honest with the patient and actually explaining that you don't know. And this is going to take place around about minute 7. But the way in which you do it is so important. If you just go, actually, I don't know anything about Down Under syndrome, so I really won't be able to help you today. as that sounds and feels, that is not helpful. And so Flanagan and Roylance talk about the art of the gentle letdown, which helps maintain rapport. I'm afraid I don't have a great knowledge of Down-under syndrome. And as a result, I won't be able to answer all your questions today. Down-under syndrome is an uncommon condition. It's not something that I see on a day-to-day basis, and as a result of which I'm not familiar with the condition and how it's managed. So, what do we need to do? And this is the point at which you've actually got to think about what were the issues or questions that really need addressing, and actually divide it up into things that you can do and things that you're going to ask the patient to do. So it may be that you're going to look at the medical literature, you may be talking with your GP peers, you may be talking to a local consultant, you may be talking of course to a regional consultant to actually gain the information that the patient needs. You may be asking the patient to contact his brother, find out any more information that he may have subsequently acquired since that initial telephone consultation. The brother may be able to signpost him to some resources. The patient, of course, may also choose to go on the internet and try and find some resources that not only help answer his questions, but generate questions for future consultations. So having identified what you're going to do, what they're going to do, it's important to arrange a timely review so they know that the questions that haven't been answered today are actually going to be answered in the next week. Let's meet in a week's time. And the other option that you've got is not only to invite them to the review, but also any other party that may be involved that the patient wishes to bring along. Having done that and having agreed that, you want to finish with a summary. Just let me recap. The things that I'm going to do are, things you're going to do is, and we're meeting in a week. Is that okay? And then you've got real clarity, and as has the patient, as to what questions are being addressed. Sometimes, in terms of clinical management, you've actually got enough information from that initial phase to come up with some elements of a clinical management plan. And again, this can be integrated into those last 3 minutes of the 10-minute consultation. So by taking this approach, because you've established and maintained rapport, you've been interested in them as a person, you've gained a great insight into what the actual situation means for them. You've been able to gently let the patient down with regards to your limited knowledge, so maintaining and continuing rapport, and have agreed a plan that is actually going to meet the patient's needs, but not today. You are very likely to score marks in the interpersonal, the data gathering, and the clinical management domains. Now, one thing I would advise is for you to actually have the link below the YouTube video, and this is actually a link of Dr. Roylance demonstrating the down-under consultation and utilising the skills that Flanagan and Roylance advocated. And you can actually see how it works, the conversational language that is used, how the structure is applied to deliver a successful consultation.